Hello and welcome. My name is Mina Niknazimi. I will be presenting the subject of OccluSense to you today by the company Bausch. I hope that everyone can hear me and see me. I'm going to open the chat and try and have a look at it during the webinar. If you have any questions, feel free to pop them in the chat or ask them at the end of the webinar. Okay. If you have any technical difficulties, also make yourself seen. And if I don't hear from you, I am assuming that you can hear me and you can also see the correct screen. And then we can get started. Okay. Right. I don't see my screen. One moment. I just need 1 second. Okay, perfect. Right. So, second time lucky. Here we go. Much better. Right. Okay. So I'm hoping you can see my screen again. I can see everything perfectly, and we are therefore ready to get started. All right, so today I will be talking to you about the subject of OccluSense, a product by the company Bausch. First and foremost, a little bit of introduction about Bausch. Established in 1953, Bausch is a family company that was founded by Dr. Hans Bausch, who was a dentist himself. And he developed the articulating paper with the progressive color transfer in 1953, as he was aware of the importance of the masticatory forces and their effect on the occlusion. And to us, occlusion, and probably to many other dental professionals, is the contact between the teeth of the upper jaw and the lower jaw. So any restorations, for example, with fillings or crowns, they mean that there is an intervention in this system and they should be monitored and adjusted by the dentist accordingly. As you can see in this video, there's the production side of the company Bausch. The products are produced in Germany, a couple of hours away from Cologne, a little city, in the Eifel, it's called. And there the produce is produced and then prepared for shipment to be shipped out. OccluSense is occlusion in a digitalized manner. And I would like you to think about the concept of what occlusion even is. It's a very straightforward question to ask, but I want you to think about what you would do to visualize the static and the dynamic occlusion in your patient's mouth. And then think about what you do currently to test this on our patients. The current standard involves the standard articulating paper in different shapes, in different forms. You have them in pre-cut strips. They can cover the full dental arch and they can be rolled for you to be cut in the sizes that you deem necessary. Obviously, there's also different colors and various thicknesses that can be used, starting with a foil thickness of 8 microns thin. The current standard to check occlusion in all dimensions is primarily done using different colors. So we use, in this example, red for static occlusion, black for protrusion. You can see green being used for mediotrusion markings. Oh, in this case, it's green for lateral intrusion markings and blue for mediotrusion markings. And as we all know, this is a very time-consuming matter for any dental professional, especially if this process has to be repeated a couple of times. Which is why OccluSense then comes into play. So with OccluSense, you have occlusion in a digitalized manner, whereby you have a wireless handheld, an electronic pressure sensor, which you can only place into your handheld in the correct way due to the asymmetric. Sorry, due to the asymmetric pins and holes. Disturbance done. Due to the asymmetric pins and holes in the handheld and the sensor. And once the sensor is then inserted into the handheld, you can insert the sensor into your patient's mouth and ask them to produce any movement that you want to have recorded. And as you can see in this visualization, the markings are also left in on your patient's teeth. And this information is then transferred wirelessly onto the iPad. And the visualization you can see on the iPad here. I will go into how to read them in more detail in just a moment. So the first example of the insertion of the sensor was a static movement, and the second is the dynamic movement. And for those of you who don't own an OccluSense system yet, I will briefly take you through how it actually works. So we saw a handheld, which is as big as a hand and can be held in your hand, and an iPad with the OccluSense iPad app. The app can be downloaded for free on the Apple Store, and sensors, which are currently available in 2 different sizes. So we have X and XL, whereby these differ in width rather than length. And these highly sensitive pressure sensors are able to detect 256 different pressure levels while still remaining 60 microns thin, and yet still provide very good flexibility and the thin material to insert into different patients' mouth openings. And one, to me, very extremely important factor, the red color coating, whereby when you use this method of occlusion control, the marks are still left on your patient's teeth, just like it is with standard occlusion papers. How does the OccluSense work? So to first get started, you need to do an initial setup. You do this only once. So the first time you set up your OccluSense device, you need to ensure that your iPad is connected to a Wi-Fi connection, and then you can open up the OccluSense app and start your initial setup. The app will guide you through every necessary step. So once you then open up the app and the Wi-Fi connection is detected, you are then prompted to carry out a couple of steps where you can register the system. So tell the iPad, who are you? Tell the handheld which one is your iPad, and connect everything together so it all works without any technical difficulties.
Open your OccluSense iPad app, tap on menu item, Settings, then choose Handheld Registration. Fill in the registration form. Please enter country, name, first name, street, zip code, city, and your email address. Tap the register button to send your registration data. A confirmation email will be sent to your email address. Open the email and press the confirm button. If your registration was successful, a green tick will be displayed.
So once you've done your initial setup and you have finished the registration of your system, you're ready to go. Another short video that I've brought for you today is regarding the sensor test. So I just want to show you how to carry out this sensor test because it's very straightforward and easy and something that everyone with an OccluSense device should be doing whenever prompted to do so.
To initiate the sensor test of the handheld has to be connected to the app first. Now go to Settings in the OccluSense iPad app. Having your handheld and the test sensor ready. Now tap on Functionality Test Handheld. You will now be asked to insert the test sensor correctly and to close the sensor flap. The pink-colored control button to start the function test. The function test starts now. The result of the function test is displayed in the app. Now, remove the test sensor from the handheld and put it back in the storage box.
So in a similar way to the actual sensors, the test sensor also has asymmetric holes which fit to the pins inside the handheld, whereby you are only able to insert this in the correct way and then close the handheld flap. So you don't have to worry about putting it in the wrong way. Okay, so why do I need OccluSense? In order to understand why it might make sense to switch up your usual occlusion control methods, I want to look at both. So the standard methods of occlusion testing with papers and foils, and also OccluSense, and compare them to one another. If we now look at this pathway, in order to get from checkpoint 1, which is the very initial contact on antagonizing teeth, to checkpoint 2, which is the pathway in between the initial contact, and checkpoint 3, the maximal intercuspal position, you would have to continuously monitor this pathway. So from 1 up until point 3 for an exact understanding of the three-dimensional process of occlusion. And in this scenario, so this is the scenario when you're checking your occlusion with papers and foils, you actually only have the opportunity to look at the occlusion at checkpoint 3, so right at the end. And you can think of it like taking a picture of one moment in time. So it's a single moment that you are currently capturing with your papers and your foils. Whereas occlusion testing with OccluSense actually allows you to look at this process at any given moment in time. So as occlusion as a whole does not consist of just the final jaw position, but also the entire movement before the final jaw position, you could now monitor this process over time. And if you like, you can then think of this as a video recording of any moment whereby you can take a look at what's happening at the beginning and not just the final jaw position. But do we really need that much in-depth detail for every single treatment we carry out? If we take an implant as an example, we know that the threshold for tactile sensitivity of an implanted construction is about 8 times higher than that of the threshold of vital teeth within their natural periodonts. So any occlusal interferences, as for example, a construction that is slightly too high, it will not present itself with the same symptoms as it would in vital teeth. Therefore, this disbalance within the system will be directly transferred to all the surrounding tissues and leads to, for example, craniomandibular dysfunction. There may be plenty of other indications whereby an OccluSense can aid in better and more precise diagnosis making, So you are able to detect hidden contacts, but also interference contacts quite quickly. You can look at early detection of combined periodontal damage due to incorrect loading, and look at the force distribution of the entire dental arch, which also means that if you are avoiding incorrect loading, you can avoid chipping. You can look at the record, you can look to record dynamic occlusion on splints and compare your data over time, and also look at recordings of orthodontic changes as well as occlusal movements. And what you're always doing is you are documenting everything you are doing and can use the visualization for patient education. Just like any other CRM system, you have a database whereby you can add your patient's data by, in this case, tapping the add button and then adding your patient to your database. You fill in all the blanks with all your patient's details, and the patient number can be identical to the patient number of your dental practice database so that you can trace each individual back to also your own patient database. Once your patient is added in the system, you can activate them and also look at any past recordings. Once you've set them active, a new recording can be taken, and the system will ask you to adjust the time and the frequency you will need for this recording, which you could also do via the handheld green button, and you don't have to necessarily be doing this via the iPad. And then you're ready to get started. So you place the handheld or the sensor into your patient's mouth and instruct them to conduct the movement you would like to have recorded. The data would then be automatically transferred to an iPad, and that's what it would look like. The colored marks will still be left on your patient's teeth, and then you can make any decisions that you need to make to adjust your patient's occlusion accordingly if needed to be done so. You can also press the pink button to start the recording. So this doesn't have to necessarily be done via the iPad. You have two options in this case. And if you press it twice, it will start the recording straight away. If you only press it once, it will start the recording once the once the sensor detects a pressure change. So once the biting process starts. We've had some quite intelligent people draw up a manual for use, which you can download on the OccluSense website, but it will also be delivered with any OccluSense starting kit. As you saw in the previous example, the iPad recording consists of a data set that is differentiated through colors and columns, and I want to talk to you about what they actually mean. The colors tell you more about the pressure that is being applied and the size of the contact points. Green points represent an area of contact on a wider surface, whilst orange and yellow are something in between, and red represents a punctual contact. To understand this a bit more clearly, I want you to take a look at the load of this bridge that is being transferred onto the two pillars left and right. And the left pillar has a wider surface contact to the ground, which is characterized by green columns. And the right pillar has a punctual contact surface to the ground, which is why this is red. The amount of pressure that is being applied here on the left and right pillars is exactly the same. It's the only difference is the surface area. So this is why the height of the columns is the same. The amount of pressure is the same, but the surface area whereby this is being applied differentiates itself, which is why the colors are different. This is another example of a quite unrealistic bridge, trying to just make it more clearly what the colors and the columns and the height of the columns actually mean. We are also always talking about a relative pressure change. So the height of the columns, they don't actually give you an indication of the exact amount of force that is being applied in a numeric value, but it's a relative change as a combination of the entire pressure that is being applied in this dental arch. And to now transfer this knowledge of the height and the colors of the columns onto the three-dimensional movement during mastication, I want you to imagine that you are standing on a plate covered with needles, barefoot. And apart from the pain that you are experiencing at the beginning, what you are also feeling is that every single needle that is going into your sole of your foot is applying a different amount of pressure onto a different part of your foot. And if we now take a little slide out of this needle plate, and remember that these needles are all being compared to one another, so the pressure that is being applied is being compared to the neighboring needles, then you can see that well, my finger was too fast, I'm sorry. We are now again standing on the plate covered with needles. And taking a little slide over. And here you can see on the left-hand side, those two needles that are being compared to one another are being applied with a different amount of pressure. And because this pressure change is big, we're talking about a punctual contact here, which is why this is red. If you then move over to orange and yellow, you can see that the amount of pressure that is being applied to the two needles, or more the pressure difference, is a little bit less than what you saw in the red one, which is why these are orange and yellow. And on the very right-hand side, you can see that the pressure difference is very, very small. So the pressure that is being applied to the neighboring needles is very similar, which is why we can talk about a wider contact surface. In hindsight, this means red columns indicate high spots. They indicate initial contacts or standalone contacts. So this is our punctual contacts. Whilst green indicates a low pressure difference. So this is the case for planar contacts on, for example, abrasive teeth, or adjacent contacts with similar pressure. What you should remember, in this case, red is only a color. It doesn't mean alert. It doesn't mean, oh, I need to adjust my occlusion now. Absolutely not. It simply indicates that in this area, you have a high pressure change. This is a punctual contact. And like our ABC contact, sometimes we are actually looking for punctual contacts. And if this is something that you are looking for within your occlusion protocol, then it's absolutely fine. If it's not, then you adjust your occlusion accordingly, but red is only a color. And what we should always keep in the back of our mind when we are evaluating our readings is that these colors are a relative pressure change and they're being compared to one another. And that is what you should remember. Okay, so let's take this example of an OccluSense reading for static occlusion and try and analyze this. What we do see is that in the right molar region, I'm missing a few red columns. So everywhere within my dental arch, I have quite a few red columns over here. And then in the right molar region, they're missing. So this could make me think, oh, okay, so I have less pressure there. Don't be fooled. This is actually not the case. If you take a look at the percentage readings being marked outside the dental arch, then you can see that actually the right molar region has 44% of the entire pressure being applied within the dental arch in that quadrant. So 23 and 21, 44. It's nearly 50% of the entire pressure. Only because there's no punctual contact doesn't mean there's not a lot of pressure there. There is a lot of pressure there. It's just being distributed on a wider surface area. And this is also signified by the quadrant in this circle being in a different color. So green, as I told you before, is a little bit wider surfaced out, and orange in this case means that we have a little bit more pressure here. And the same level of information can also be abducted from dynamic occlusal movements. So here you see lateral protrusion to the left-hand side by canine guidance, and to the right-hand side, and we can see there's actually in the molar region, we have a guiding tooth. I will take you through a couple of features that I personally find very helpful in the OccluSense app. So what you can do is you can amend your viewing options and switch forward, back and forth between a 2-dimensional view and also a 3-dimensional view. So the 2-dimensional view shows you quadrants of pressure in percentages being applied, and the 3-dimensional view shows you the height of the columns. But if, like me, you want to see everything, you can also combine the two and see everything at once. Here again, a couple of additional controls. So I spoke to you about the viewing options. You can also go into a full screen mode and take a look at your OccluSense reading in a bigger picture. What you can also do is play, pause, fast forward, rewind, do some noise cancelling, which I will talk to you in the next slide a little bit more. So you have 256 pressure levels. Sometimes you don't want to know that much information. You want to know a little bit less. So you just use that little button, go up, and then you see, for example, only 50 different pressure levels to focus on what's important. Now I've explained it to you now, can save it in the next slide. You have the opportunity to look at percentiles, at quartiles, and also compare recordings over time. This is quite a useful tool for splint occlusion. So if you're looking at your occlusion of your patients 6 months after you've placed a splint, and you want to look at which influence the muscular forces had on your occlusion, then this is actually quite useful. That's the bar on the right-hand side of your viewing on the iPad that you can use to do the noise cancelling and filter the levels that you want to have displayed. Another useful feature, maybe, if you want to export any of your information or any of your readings, you can only do this. So this is the most important thing for the export of data that you need to know. You can only do this by entering the full screen mode. Only when you are in your full screen mode, the export button will appear. And then you can export and straightforward either have your data saved to documents on your iPad or to the camera roll. So PDF goes to documents, PNG goes onto your camera roll, and then that way you can export your data. What you can also export is a video. So if you actually want to take a video, add some spoken comments onto this video or some movements that you want to have recorded with your finger, you go onto screen recording, do whatever you want to do, speak whatever you want to speak, and then stop the recording and go onto your export button to then have your recording saved onto your camera roll. A couple of more details about network access, which can be downloaded on the OccluSense website. Okay, so how do we transfer all of our knowledge onto our patient's teeth? It's actually very simple. You can retrace your steps by firstly making sure that your midline in the patient's mouth is also the midline in the sensor. So you can see on the sensor at the bottom there, you have a red triangle. Some sensors have a red line, whatever it is, that's your midline. And then you insert your sensor into your patient's mouth, and this should be the midline in your patient's mouth. And now you can retrace everything back, every single point that you see in your OccluSense reading by looking at the segments on your iPad and then looking at the segments on your sensor. And that's how you then retrace every single contact point. Let's try looking at these readings together. So the blue circle indicates a 2-point regular occlusion on a molar. The orange circle is your regular occlusion on a premolar. And I want you to make sure that you're looking at the 2-dimensional, 3-dimensional, and the clinical view, because that's the only way that you can understand what is happening here. As the purple one, the purple circle, shows me a premature contact. How do I know this? By looking at my OccluSense reading, the middle view, so the 2-dimensional view, I immediately see that the quadrant in the left molar region is yellow. Why is it yellow? Because there's 50% of the entire dental pressure being applied over there. So that immediately raises my attention. I'm like, why is my occlusion not evened out? Why is it not balanced? And if I then take a look onto my clinical situation, so the teeth on the left-hand side that you see here, I see that my tooth 36 actually has the buccal contact, which has nothing to do there, and a simple fabrication in this case evened out the occlusion and balanced it out. The same you can do with dynamic occlusion. Here you can see a non-balanced group guidance with most of the pressure being located in the bottom right quartile and a single contralateral contact antagonizing this movement. And if you imagine tooth 36 was an implant that we had placed, there goes the ceramic chipping after a couple of months. The same level of information you can do with protrusion. And now I have prepared a couple of clinical cases for you. So this is also with the kind contribution of a couple of partner doctors that we work with, partner dentists that we work with, who have kindly provided a few cases. So case number 1, we have a female patient presenting herself with the symptoms you see outlined here: ringing in the ear, the feeling of absorbent cotton, cervical spine, and ligament sheath prolapse, a hyperactive thyroid gland, and some muscle tension in her face between the nose and the ear. Looking at her occlusion with OccluSense, we found there's a primary pre-contact on 48, some unequal loading in intercuspal position, and a final heavy load between 41 and 45. Her protrusion showed parafunctionality on 48. Mediotrusion to the left-hand side again, 48, showing parafunctionalities and no canine guidance. To the right-hand side, we had some group guidance as well and parafunctionality on 48 and 38. As she was a case of bruxism, we took a look at her main movement over 43 and found some parafunctionality on 48 again. And the control of the nocturnal movement using the RT spray showed us, again, we actually have a premature contact of 48 in centric position. And going ahead and fabricating her occlusion in just a slight way actually led to her solving the problems she initially presented herself with. So this actually helped with a lot of further symptoms other than dental symptoms. We don't always need a pathological reason to take a look at our patient's occlusion with OccluSense. So here we have a patient coming for her regular dental checkup. And you can see quite a balanced out occlusion in this case. On the right-hand side in the molar region, no OccluSense readings because she is missing antagonizing teeth in the fourth quadrant. So there's no pressure difference that can be detected here. Looking at her dynamic occlusion, the lateral occlusion to the left showed a very nice canine guidance. And her protrusion as well displayed here with OccluSense. The final clinical case I've brought for you consists of OccluSense and splint therapy. And I want you to take a look at the condylar processes on the right and on the left-hand side of this patient. And you can see that it's actually got different shapes and forms. So we have a case of hemimandibular hyperplasia. And according to the differing development of the condyles of this patient, she suffers from craniomandibular dysfunction, whereby the occlusal interferences lead to teeth grinding, especially at night. And since this patient chose no surgical intervention, our primary treatment involved preservative symptom management, whereby the night guard was fitted to protect her joints and her teeth. If we take a look at the static occlusion without the night guard, so this is the patient, this is our first clinical situation, the initial clinical situation. I want you to take a look at the occlusal interferences and as well the force distribution. And what you will find here, I'm going to rewind a little bit, is a very unbalanced occlusion. So she starts off with occlusion on the right-hand side. She actually suffers from an open bite on one side. And then via sliding and grinding, her bite closes a little bit more with nearly 90% of the entire, or over 90% of the entire dental force in her right molar region. Right, so our aim in this case is fitting a splint to even out her occlusion at least overnight. Here you can see the open bite quite well actually. And I want you to think about what you do or how you test a splint on your patients. So the way we do it, we use a shim stock protocol and try and see that we have a evened out occlusion with shim stock. What you will find with shim stock is that this is actually a very subjective method of testing occlusion, because the amount of pressure that the patient applies for every bite is different. The amount of resistance that you feel when you are pulling out your shim stock is different. And the force that you apply when pulling out your shim stock is also different for every single one. So it's a very, very subjective method, but it's still quite, I'd say, proven itself over the years because we've not had anything better than this. But this is what we did with this patient. So we fitted the splint, we did a shim stock protocol, occlusion, the static occlusion seemed quite evened out, and then we sent her back. A couple of weeks later, we've had her come in for a checkup, and she still had some pain in her joints and her teeth, which is why we then checked her occlusion with OccluSense. And what we then found, you will see here, again, please take a look at the force distribution of her static occlusion in this case. Right. I'm going to pause at the back. If you think back to the pathway I showed you at the beginning of this webinar, I explained to you that when you are doing an occlusion protocol with papers and foils, you are able to look at the occlusion at one single moment in time. It's your final jaw position, so right at the end. And if you are now thinking about the shim stock protocol that you're doing, the amount of resistance that you're receiving is evened out roughly throughout the entire dental arch for this. What you are missing, however, and this is what we did, and this is why we sent her home. But what you're missing is everything that is happening before that. So you can see as the bite advances, her occlusion changes quite radically, I'd say, until you find that final jaw position. So all of this you are missing when you are testing your occlusion with standard papers and foils. And the exact same thing can be done for dynamic occlusion again. So here we're looking at the canine guidance. In this case, in my opinion, not really evened out again. We've had to have some further fabrication done on the splint to even it out more and set it up in a better way. Let's put it that way. And the same with protrusion as well. So maybe the most relevant question for you now, does OccluSense replace articulating paper or foil? It really depends on the indication. That's my answer for you. So if you like, you can compare it to X-ray imaging. Although X-rays of a single tooth are indispensable for specific treatments, let's compare this or take it as a comparison to standard occlusion foils and papers. You can still use panoramic X-rays for different indications to give you a faster overall overview. And in this case, I would use and equal it out with OccluSense. However, one does not really replace the other. So depending on your indication, sometimes you need both, sometimes you can use one. It really depends on what you need to do. What you are, however, remembering is that papers and foils they show you a snapshot of a single moment in time, whereby OccluSense gives you a video recording over a given moment in time or given process in time. The algorithm that I personally use is the following. So first and foremost, I use OccluSense to give me an overview of the pressure, an overview of what is happening. Is there anything that I need to be looking at in more detail? I do fine adjustments with standard papers and foils and control my occlusion with OccluSense right at the end. And what you are always doing automatically is you're documenting your work. There's experts all over the world who have kindly shared their feedback and also their clinical cases with us. I already teased that a few of the clinical examples that have presented to you today have been provided by other dental professionals, because we have many interesting cases being shared in various specialties. So whether it's conservative dentistry, prosthodontics, craniomandibular dysfunction, and also implant prosthetics, there's plenty of dental professionals all over the world who are using OccluSense in a successful way. And for you to get started, you will need an Apple iPad. Those produced in the year 2014 and later are supported. You need an iPad app, which can be downloaded for free on the Apple Store in different languages. You need a Wi-Fi connection and the OccluSense system BK5000. This will provide you with everything you need to get started. You have test sensors in there, or a test sensor. Then you have sensors to get started with. You have an inductive loading station. You have the handheld and instructions for use manual, as well as a sleek little suitcase where you can carry all of your things in. Thank you very much for your time and your attention today. In Germany, it's a very sunny day. From wherever in the world you have dialed in today, I hope it's sunny over there too. And yes, I'm open for any questions that you have. feel free to pop them in the chat or use your mic.
Hello, Mina. Thank you for the presentation. Greetings from Romania here. I do have some questions as I've had the opportunity to work with OccluSense in recent few months at the university. So the first one is a bit of a technical question. It's about the Wi-Fi. I do understand that it goes through the Wi-Fi, the information, but we had some trouble when moving the setup from one room to another where the same Wi-Fi was not present, and we had to restart the whole process of registering the iPad with the OccluSense. Is there some way to avoid this stuff when moving the device, or it has to be connected on the same Wi-Fi?
Okay. I have to admit, I am really no technical expert. I'm more of a user as well, but I do know that there is Wi-Fi, what are they called? Those that intensify the signal. It's something, especially in the university, I assume it's a bigger place, so the Wi-Fi connection or the stability will be different in different rooms. So there are some connection strengtheners that you can use, but if you need some more in-depth detail, you should definitely get in touch with our technical team. They will absolutely be able to assist you with that.
I see. Well, that's quite annoying when moving the device from one place to another because you have to restart the whole process like you just bought the device all over again, even though it's the same iPad and the same device. It's like a security feature or something, but it won't let you do nothing unless you restart the whole process manually and also restart from the back of the OccluSense with the pin. There's a restart button like for some devices. Anyways, maybe I'll write an email to your technical team if there's
They
some.
will definitely be able to assist you. I'm sure there's a good way to solve this because we have used OccluSense in different universities where they have the same issue with a bigger area and different rooms and different connections, and this does not happen there. So get in touch with them. There is a solution, absolutely.
Thanks a lot. Also, some applicability questions, if possible. What about the frequency and the time that we can adjust when doing an registration? How can you help us in understanding which type of frequency we should use? How does this influence the registration? And what about the time of registration? How can we put this into practice to better suit our registration?
It really depends on what you're looking at. So a static occlusion will need less time. So I would say maybe you use 10 seconds and do a couple of bite closings, and then you have two static occlusions and can kind of even them out and take the middle of it. And the frequency tells you more about how many snapshots are being taken in 1 second. So the higher the frequency, the more in-depth your reading will be. And depending on the level of information that you need, you can adjust your frequency and your time accordingly. In the same way, when you're doing dynamic movements and you want to look at lateral protrusion to the left, go back to static, lateral protrusion to the right, you will need maybe more than 10 seconds.
I see, but does this, is there a way to, let's say, get rid of the frequency settings with the filtering? Like if I'm using the highest frequency, is it true that the device registers the whole pressure spectrum, let's say, and then with filtering, I can just filter out how much I want to see on the screen, or it does influence the registration if I'm choosing from the start 100 Hertz or more?
It shouldn't influence your registration, no. It's just a difference in the amount of detail that you are receiving. And yes, you can then, in the end, if you're registering with the highest hertz, then use the noise filtering to then go and look at less detail. I hope that answers the question.
How do we instruct the patient for biting? I know the sensor starts when it feels the first pressure, or manually, just as you explained, but should we instruct the patient to bite multiple times during the same registration, let's say in static, or maybe even in dynamic movement? Should we instruct the patient to do multiple movements or just one for the same registration?
What I personally like to do, I think this is a matter of trial and improvement because every patient is different. But what I like to do is I would like to look at their bite and at their dynamic occlusion without OccluSense. So I want to see what is their natural movement. And once I've practiced this with the patient, so you can use Optrogate optionally if this is easier for you because you can obviously see more and it's easier for you to insert the sensor into the patient's mouth. And after that, I go into live mode where I'm not recording yet, but I'm asking the patient to, again, conduct the movement with the sensor in their mouth because this is also different for the patient, obviously. And once I can see that they have got the gist of it, I start my recording. For static occlusion, I ask them to bite twice, very normally. Dynamic occlusion, I usually just do one go to the left, one go to the right. And if I sense that this was the movement that I've also observed beforehand without the sensor and it's their natural movement, then that usually suffices.
Okay, so from what I've understood, I can do both lateral movements with the same registration. Like I can make the patient do both of the movements, and I have like 25 seconds set for the registration, so I have enough time to register both movements.
Exactly, but it's easier for them if you practice it before because then you don't have any other movements within your recording.
I see. So the following question would have been about the live mode and its uses, but you just explained like we can just test before registering anything. Okay.
Absolutely. Or
What
maybe
about
the
the
patient
yes?
wants to see. You can also, this is a very, very good point actually, because plenty of other dental professionals have talked about how interesting it is for the patient to understand what is happening within their mouth because the concept of occlusion is quite hard for them to understand. And when they are able to visualize this by looking at the OccluSense reading, by explaining to them, look, this quadrant is red, you are biting harder here, so we need to adjust your occlusion, it's much easier for them to understand rather than just explaining it without any visual help.
I see. What about the sensor usage for the same patient? Of course, they are disposable and they are for one patient, obviously, for obvious reasons, but how many registration can we do with the same sensor on the same patient for a session, let's say?
I love this question because I purposely leave this information out. And at the end of the webinar, it really makes me happy when someone asks because, I know that everyone has been listening. Okay, it's a great question. One sensor can be used up to 20 to 25 times. So one in the same one without any effect on the quality of the pixels or the sensors within this sensor. The electronics of the sensor will not be influenced within 20 to 25 times. After that, you should definitely change. And as you've said, for hygienic reasons, obviously one sensor only belongs to one patient. What you cannot do is you can't sterilize this sensor. It's an electronic device and it cannot be sterilized. So you can't put it into a sterilization machine and reuse it. This is not possible. If I have a prosthodontics case for a crown fitting or a bridge fitting, also implant prosthetics, I use the sensor on my patient and I know they will be back in a couple of weeks, they will be back in 4 weeks. And that sensor I then put into a closed bag, a closed little plastic bag, and I keep this sensor for the patient when they come back in 2 weeks. I would not keep it for the patient for 6 months. We can't really foresee what will happen within 6 months and what bacterial colonies will be built within the sensor. But in my experience, a couple of weeks have not been a problem, as this is not really an intrusive act when they're biting on the sensor.
Thank you for answering the questions. That will be all for me.
Any other questions? I've left the last slide open for you to note down my email address. If you have any questions about cases, any questions about the device once you get started, any clinical questions, as I said, I'm really not a technician. We do have a technical department that can deal with technical requests, but any other questions, feel free to note down my email address. So in the future, if you have any question marks, feel free to drop me an email and we can certainly discuss anything that comes across later. Other than that, I think the chat is also clear. If there's nothing else, then I will thank you again for your attention today on a Saturday as well, and hope that you all have a very lovely weekend. And yes, that would be all from my side. Okay. Perfect. Right. Okay. You're very welcome. It seems there's no more questions, so then I will take this opportunity to say bye to everyone and thank you again.